Topic has been neoplasia this morning. Unfortunately, I forgot to start recording at the beginning of this class day, so I'm just going to quickly review what we've covered. We covered the traits of cancerous cells. We differentiated, first of all, tumor from cancer, cancer by definition being metastatic. Tumor can be cancerous or not. It could also be benign, and benign tumors tend to be encapsulated, and they tend to be more similar to the original tissue, whereas whereas carcinogenic cancerous cells tend to be very, very different from the cell of origin. We talked about our genetic pathways, where carcinogens can cause mutations from proto-oncogenes into oncogenes, or can alter tumor suppressor genes. So oncogenes being something that is going to increase the cell cycle, and tumor suppressor genes being something that would, in a normal situation, cause apoptosis, but when mutated would fail to do so. So we covered that. Some other traits of metastatic cells is that they're going to be capable of breaking through basement membranes. They may develop collagenases and proteases in order to do that. They may develop angiogenesis, the ability to create new blood cells to support their own growth from the inside. And if it's going to travel hematologically via the cardiovascular system, they may develop a more robust cytoskeleton as well. So it's actually very rare that you would be able to have all of those mutations in a single cell, but obviously it does happen because people do get cancer. Stage grading is very diverse depending on the system, but we can generally classify it based on localization, whether or not it's made it out to the local lymph nodes and whether or not it's made it past any connective tissue barriers. This is a PET scan showing metabolic activity, overlaying a CT scan so that we can discover where that metabolic activity is. And our overall cancer statistics are nearly meaningless because individual cancers will have very, very different survival outcomes. We talked about cancer risk factors, standard cancer therapies, and newer cancer therapies and what they are like. So go ahead and move on to our neoplastic disorders as collected from throughout the entire coursework, so collected from different systems. First one I want to talk about a little bit is breast cancer because it's such a big topic. It impacts so many women worldwide. It's unbelievably common. There are a variety of different kinds of breast cancer. The main takeaway here is that most breast cancers come from one of two cell populations: a duct cell, a cell from the duct of the exocrine gland, or a lobular cell, a lobe of the exocrine gland. So these are both going to be glandular in nature. That's where most of our breast cancer cell populations arise from. When I wrote this slide in particular, I was really fresh off of a pathology conference, and I was really, really excited about some of the things that I learned at this one patho conference. And part of it was some of the things that they were doing in diagnostics. Part of it was this whole idea of low-grade DCAS, ductal carcinoma in situ, and that's actually a misnomer. Ductal carcinoma, that word carcinoma indicates a cancer, but a low-grade ductal carcinoma in situ is generally considered benign. So they are considered renaming that. And it just kind of brought up this discussion at this patho conference of, you know, patients are going to Google their disorder. They're going to see the word carcinoma. They're going to find out that it means cancer, and they're going to be terrified. So a lot of what's up here is just a lot of changes to breast tissue are in fact benign. A change to breast tissue does not automatically mean breast cancer, right? That's what a lot of this up here is. Yeah, it can change from month to month, breast tissue, hormonal changes, change density, absolutely. Okay, so you know that's not nearly enough for breast cancer, but it's all we're going to do because there's so much content. The big takeaway is, again, that general cancer physiology and applying it to these new cells and these very specific cell populations. Renal cell carcinoma, I mentioned when we get to urinary, we'll go very into detail about the staging system for renal cell carcinomas. These are metastatic. They do tend to have a metastasis via the cardiovascular system, which this is one of the few that actually does travel hematologically. You can remove a kidney. That's the good news, right? The problem here is that this tends to be asymptomatic until it's advanced. A kidney, again, since you can work just fine, your physiology can be fine with one kidney, you may not notice the lack of kidney function. It may be a while before you experience pain radiating from your kidney as a result of renal cell carcinoma. So these do tend to be diagnosed late. Yes?
Is it normal to have like carcinoma of one kidney, or if you have one kidney affected, does it usually come in pairs?
As far as I know, it can start unilaterally. I don't know the answer to that. That's a good question. Is just for the sake of the recording, would this be something that occurs bilaterally? If it's happening in one, it happens in the other. Again, it's luck of the draw, right? It's where did that cell come from? Where's that cell going, kind of thing. I've actually seen a renal cell carcinoma in an autopsy only on one occasion, and it was only in one kidney, and it was very small. It was that big at that time. It was not the cause of death. Any other questions about, and again, we will revisit renal cell carcinoma during urinary. Yeah, there's generally the 1 through 4 that sort of applies to a variety of things, but breast cancer's got a much more elaborate staging system, just as an example. One thing the kidney has that I'll point out, the kidney is encapsulated by something called Gerota's fascia. I might have mentioned it in AMP2, even though it wasn't necessarily on your list. So metastasis beyond Gerota's fascia is a major event for the staging system. Okay, prostate cancer. When we get to reproductive system, we'll talk about comparing and contrasting prostate cancer versus benign prostatic hyperplasia, which is much more common. Prostate cancer tends to happen more in the periphery of the prostate. This is a cross-section histological specimen of a prostate gland with a prostatic urethra located centrally here. A lot of these cells in the periphery are the progenitor cells for neoplasia for prostate cancer. It is the second leading cause of cancer death in men. A lot of them are going to be adenocarcinomas, and we don't really have a cause for it. Etiology is unknown. But we do suspect that it's going to be related to hormones. This is going to be specific to men or biologically male people with a prostate gland. Dietary, viral, genetics could play a role as well. When we do discuss benign prostatic hyperplasia, that BPH, it's usually going to happen centrally closer to that prostatic urethra. So BPH is more often than not going to be the cause of struggles to urinate in men. But here's the rub, is if a tumor from the periphery of the prostate gland has grown enough to impinge the prostatic urethra, at that point it's rather advanced. So again, this is one of the reasons why it's a leading cause of cancer death, is it's not causing problems until it's advanced. And that's a common theme in cancer and cancer treatment. How's my pace? Do you want me to slow down at all? We're good? Yes, please. Only the important stuff. Are there any questions? Take a beat.
The prostatic urethra, is it usually just round when there's nothing impeding
Oh no, it's soft tissue. So there's also something in histological specimens called artifact, where it's a very, very thin layer of something. So it's not always exactly shaped the same way. But think of like the way an artery or a vein looks like in a cross section in histology, where especially if it's like soft-sided, it's going to be collapsed if there's nothing in it. That's what's going on there. Okay, gastric carcinoma. This is going to be stomach cancer. It's going to be more prevalent in some specific areas. Japan has a 10 times higher rate of gastric carcinoma than America does. Yes. Does anybody want to make a guess as to why? Probably dietary. What about diet? Probably not sodium. We're pretty salty over here. No, they're pretty good on fiber, I would argue. What's that? Mercury, yeah. So fish, a high seafood diet. Mercury bioaccumulates, just pure mercury, not like the mercury in vaccines. That's a topic for another day. But let's say, the phytoplankton gets the mercury, the fish that eats the phytoplankton stores all of the mercury from all of the phytoplankton, the fish that eats the smaller fish, stores all of the mercury that's ever accumulated in that fish, and so on and so forth up the food chain until the biggest fish is going to have all of the mercury of everything it's ever eaten, essentially. So yeah, seafood can be a little bit high in mercury. That doesn't mean don't eat seafood. It just means we need to stop polluting. Is really what that means. And that's just a hypothesis. I'm not saying that's exactly what this is, but it's a pretty strong argument. So again, toxic exposure of the stomach lining being a major player here. I do have a note here. Your textbook says 5-year survival rate is 10%. I have a note in my notes because I had learned otherwise elsewhere. If the cancer is diagnosed and treated before it is spread outside the stomach, 5-year survival rate is actually 65%. So again, your textbook's kind of simplifying some survival rates in its cancer materials. And yeah, if it's detected and treated localized, you got a 5-year survival rate of 65. I was going to show you something, and I forgot to show it to you before. As long as I may, I'm sharing my screen good. There's something it's a webcomic. Let's do XKCD cancer lanes. Okay, so if you ever have a hard time communicating cancer treatment to a patient, this is XKCD. It's written by Randall Monroe, and his, at the time, girlfriend developed cancer, and he stopped producing webcomics for a long time, and when he came back, he started writing about cancer for a while. And I think he did an excellent job communicating the subjective experience and actually some of the science, because he's actually literally a rocket scientist. That's his background, so he's a heavy sciences guy. So he's talking to his friend. This is him, this is his friend. He always draws stick figures. He can probably illustrate much better than that. He chooses not to. So were you guys out of the woods? We don't know. Well, did the treatment work? We don't know. I always assumed that when you got cancer, they gave you a prognosis, then treated you, and at the end of the treatment, either you beat it or you died. And I knew sometimes it reoccurred, which I assumed meant back to square one. But that turned out to be not quite right. Once most cancers spread out into your body, they're incurable. If your 10-year prognosis is 60%, that means a 40% chance that some cancer will slip past the treatment and get out. So they kill all the cancer they can find, and then you're a survivor. But your odds are still 60%. They can't scan for individual cancer cells. The only way to know if it worked is to wait for tumors to pop up elsewhere. If you go enough years without that happening, you are in the 60%. And often the first sign is a cough or bone pain. So you spend the next 5 or 10 years trying not to worry that every ache and pain is the answer to the question, do I make it? So here's what it really looks like. You get your treatment, and then here you are at 1 year. Maybe you died, maybe you lived. Here you are at 2 years. Maybe you died, maybe you lived. Here you are at 3 years. And it never ends. Once you're a cancer patient, you're always a cancer patient. It's a permanent state. And so we get to, man, fuck cancer. Seriously. And I try not to drop F-bombs, but there you go. So each quarter of the lanes from left to right corresponded loosely to breast cancer stages 1 through 4 at diagnosis. It's really, really solid science as communication. I think it's an excellent education tool for what cancer treatment actually means. Okay, let's go back to this guy. Realign my recorder. There we go. Any questions about that? Glioblastoma multiform. This one got some press recently because of John McCain. So this is glial cell. This is rapid growth of a glial cell in the brain. So usually it's going to be, the cell of origin will be an astrocyte or an oligodendrocyte. It'll be really fast growing, and when we get to our neuro unit, we'll talk about the significance of intracranial pressure. You've got limited space in that cranium of yours. So if a glioblastoma multiform is growing very fast, it is going to increase intracranial pressure, and we'll eventually learn the phrase, that's going to decrease level of consciousness. This is going to be life-altering very quickly and progressively. So the symptoms will be congruent with any space-occupying lesion of the brain. It depends on where that lesion is, what the effect is going to be. The reason we worked so hard in neuro was to understand what each region of the brain does so that we can understand if there's a tumor there, what the result is going to be physically. It is the most deadly form of brain cancer. Most of our brain tumors are going to arise from glia, not from neurons, because neurons in an adult are non-mitotic. They don't undergo mitosis. So all these non-mitotic cells, not 100% immune, but a lot less likely to develop into cancerous cells than mitotic cells, just because cancer needs mitosis. Yes? I mean, it's so fast that you're going to have neurological symptoms. If you ignore them, then that's really bad. But even if you catch it early, this one has a poor prognosis. And again, it's in the brain. So any tumor that grows, if you're going to go in and do surgery for that, you're going to be removing parts of brain that have functional significance. So there's pretty much, I'm sure there's a variable prognosis depending on when you get it, but it's still, this is the one that I fear. If I have to be afraid of something. I mean, there's plenty that I fear, and the cancer is not a good one to have. I don't know. We can find out if it's becoming more prevalent. I don't know what the statistics are, if it's increasing or decreasing. And again, we don't have a specific causative factor for this. If maybe, exposure to environmental pollution is causing it, something like that, potentially that could be the case, but I haven't heard anything about it. Could be seizures, it could be, and again, it's going to be based on where it is. It could be as simple as like drop foot. Something like one day your foot is not working in your stride the way it should be. Like multiple sclerosis can pop up like that too, right? It's just something in the brain is not what it should be. So any neurological symptom. I could see seizures being a major part of that. Yeah.
Seizures, but she did live in a particular part of Florida where like tons of people who lived there for short times ended up getting
Gross. So the commentary that's going on in the background that's really interesting is that a certain population in Florida has very elevated risk of getting glioblastoma multiform. We should find out what was there. Yeah. Yeah, look into that and let me know, or we can look into it over break. Okay, so another one is malignant melanoma. This is another one I fear as a very, very pale person, melanin deficient as I am. So we'll address this once again during our skin lecture. And this is going to be a malignant disorder of melanocytes. Of the three major skin cancers, which are basal cell carcinoma, squamous cell carcinoma, and malignant melanoma, this one's the least likely between those three, but it is the most deadly of those three. So it is the one to be most concerned about if that's the diagnosis. It's highly malignant, it's highly metastatic, it does travel very easily. All right, any questions of that before we move on to malignant disorders of white blood cells, which will be our segue into our blood? Nope, okay. So, in general, you've got some major categories here. You've got leukemias and lymphomas. Leukemias tend to be circulating tumors that involve blood and bone marrow. Lymphomas, by contrast, tend to localize in lymphatic tissues. So think of your lymphoid organs, your thymus, your spleen, your lymph nodes, things like that. That's where you're going to find lymphomas specifically. And then plasma cell myelomas. Now remember, this is a B cell. You should remember from immunology lecture that B cells, you have memory B cells, and then they undergo mitosis, they create plasma cells. That's the plasma cell we're talking about. Yeah, plasma cell myeloma are transformation of B cell plasma cells, but they tend to localize in bony structures. When you have disorders of white blood cells in general, just think about the normal function of those white blood cells. It's immunological, it's a cleanup crew, it's going to fight infection. So if a person is going to develop a malignant disorder of white blood cells, they'll probably end up with signs and symptoms associated with the immune system. Yeah, question.
Sorry, real quick, with the plasma cell myeloma, if it's a tumor on a body surface, how do they tell it from like osseous?
So when we're doing biopsies, as I understand it, and again, this is a clinical thing, as we biopsy these structures, we'll look for cell markers to determine cell of origin. So if it's like a chondrocyte was the cell of origin, it's going to have some of those traits of chondrocytes and produce some of those proteins associated with cartilage. Whereas if it's a plasma cell myeloma, it's going to have some genes associated with producing antibodies expressed. Yeah, for an example. And that was really, really big picture and potentially inaccurate. But that's as I understand it. Yep. Okay, so signs and symptoms of malignant white blood cells is recurrent infections, unexplained fevers, enlarged lymph nodes. For some reason, this is being weird. What? No, not that one. There we go. It's just blocking that word. Fix that real quick. Okay. Now, you should remember from your blood smears, a normal blood smear should be mostly red blood cells. If you see a lot of white blood cells, it means a couple of things. It could mean infection or it could mean malignancy, right? A lot of our naming conventions, not all, but a lot of our naming conventions came from the stem cell lines. This is another thing I made you learn to name P2 for this reason. The difference between the lymphoid stem cell line and the myeloid stem cell line. Myeloid stem cells give rise to most of your blood cells. 4 out of 5 of your white blood cells, your neutrophils, your monocytes, your basophils, your eosinophils, as well as your red blood cells and the megakaryocytes, which give rise to your platelets, right? So the progenitor for that is all one cell type. It also means, since this is a lineage, you could technically have a form of neoplasm that impacts multiple blood cell types. The lymphoid stem cell line gave rise to only the lymphocytes, which are B lymphocytes, T lymphocytes, and natural killer cells exclusively. So these two act only in specific immunity. And so in this, if you have a lymphoid neoplasm, it's more likely to impact something for specific immunity. And do you guys remember natural killer cells? What do they do? Kill everything identified as other, including cells that are sufficiently mutated, such as, now that we've had cancer lecture, cancer cells. So does it make sense why they would attack cancer cells now? The sufficient mutation that it's no longer recognizable as cell. It's like a name tag. Yeah. Mm-hmm. Yeah. Instead of saying hi, I'm Reeves, it says hi, I'm Rives. They're like, that's close enough. We're good. Yeah. We like our natural killers. Let's see. So we can have an increase in total white blood cell count. In some cases, you would see a reduction of white blood cell count. You may also see things like hepatomegaly or splenomegaly. Why would you see hepatomegaly and splenomegaly? Sort of. They're getting stuck there. What do we mean by they're getting stuck there? Your body's trying to filter them out. Your spleen, the job is to break down dead and decaying, like red blood cells, for example, blood cells potentially in general. It's a big job when there are too many white blood cells. When they're mutated white blood cells, they may be detecting the wrongness of them and just trying to destroy all of them. And then it literally just fills up and clogs. And your liver has a secondary function of also doing that. You're going to see a lot of vocab words in our blood lecture. That sound kind of similar to each other, like thalassemia, thrombocytopenia. Just as a warning, anytime you have a lot of words that sound similar, you may need to put extra work into differentiating them. So we'll start with thrombocytopenia, which is a low platelet count. And what's the job of platelets? Clotting. They participate in the clotting factor. So a person with thrombocytopenia may develop Signs of poor clotting, such as petechiae, purpura, easy bruising, bleeding gums. What's occult hematuria? It's blood in the urine. Can you tell there's blood in the urine? You'd have to test it. Yeah, it's not obvious to the naked eye. You're not obviously peeing blood, but you will find overabundant red blood cells in a urine test. Okay. So some of our myeloid neoplasms, again, this is a stem cell line that gives rise to multiple blood cells. So we can have overproduction of more than one cell type. Chronic myeloid leukemia, polycythemia vera, which is red blood cells. And again, this is another one that is, I just lost my train of thought, sorry. Another one that is easily confused with some of these other vocab words. Essential thrombocytopenia related to platelets again. And then lymphoid neoplasms, including leukemia and lymphoma. So some histopathologists got really creative with their naming here. We have hairy cell leukemia. See where that came from? They looked at the lymphocyte and said, that lymphocyte looks hairy. I will call it hairy cell leukemia. It's a rare chronic type of leukemia. It's highly treatable, despite being chronic. It is related to the B cells, B lymphocytes. And it's obviously characterized histologically by the way that those B cells take on that appearance of having cytoplasmic projections that resemble hair. So have fun explaining that to your patient one day.
I know, I was just saying, I was like, imagine crying telling your family and having to say that.
Oh man, there's some way worse ones. So I'm going to pause for a second. Okay, let's go on to multiple myelomas. So plasma cell myeloma, also known as multiple myeloma, is going to be a malignant disorder of mature antibody-secreting B lymphocytes. And let's see, what else do I want to say? That's actually all I got on it. There's what multiple myeloma is going to look like. That's not what you want in a blood smear. And obviously you've got a lot of free antibodies, and that's going to cause its own problems. We haven't gotten to inflammation yet, so we haven't revisited the concept of antibodies yet, but we'll be there, I believe, next week. It's one of the problems with spacing it out the way that I chose to, is no matter what order I put it in, there's going to be something missing at certain stages. And right now what you're missing is the idea of inflammation and hypersensitivities. So revisit this idea when you've seen inflammation and hypersensitivities. Okay, we've got Hodgkin disease. We've got Hodgkin and non-Hodgkin. We'll compare and contrast Hodgkin lymphoma from non-Hodgkin lymphoma. Hodgkin disease has a slightly worse prognosis compared to non-Hodgkin disease. Now, Hodgkin disease is going to travel along contiguous pathways. What we're looking at is lymph nodes traveling along the lymphatic system. This is a lymphoma, so it does tend to aggregate in lymphatic structures. And we can kind of predict how Hodgkin disease is going to spread. Another way that we categorize Hodgkin disease is another histological feature here, this presence of Reed-Sternberg cells. We have specific cells that mutate and they take on this double nucleus structure. Not all of their B cells will look like Reed-Sternberg cells, but a certain percentage will. So here's another example of a Reed-Sternberg. This one's got 3 nuclei, which is kind of cool. And often what we find in that mutated cell, in that Reed-Sternberg cell, is the presence of the Epstein-Barr virus. What else does Epstein-Barr cause? What's that connected with? Is it strep? I don't think it's strep. Might be strep. I've always heard of it associated with mono. I could be wrong. Let me know if I need to double check my science. Okay, so Epstein-Barr virus, you had mono, that sucked, but now you got Hodgkin, this is worse. It's not to say that having that virus is going to automatically mean that you get cancer. That does not mean that. But when we biopsy the cell, we find the virus in there. Yes. Yeah.
Oh, is the difference between Hodgkin and non-Hodgkin the Reed-Sternberg cell?
That's part of it. So the difference, we're about to get to non-Hodgkin lymphoma. That's the next slide. So the difference is non-Hodgkin lymphoma does not have the Reed-Sternberg cells, and they tend to not travel along contiguous pathways. You can have some cervical lymph nodes, and then maybe the next thing to arise is going to be an inguinal lymph node, right? It doesn't necessarily have to be along a contiguous pathway. We do have an increasing incidence in non-Hodgkin lymphoma, especially in the AIDS population, and they can arise from B, T cells, or natural killer. Anything along that lymphoid stem cell line can be non-Hodgkin. Questions there?
When you say contiguous, that's lymphoid.
What's that?
When you say contiguous, what exactly do you mean?
The word contiguous, like you almost say continuous. So like I'm going to Denver and then I'm going to Colorado Springs versus I'm going to Denver and then I'm just going to pop up in Turkey.
Okay.
Yeah, like adjacent and predictable. Let's see. I believe that's correct. Hodgkin was the worst prognosis, correct? Non-Hodgkin, I believe, is the slightly better prognosis.
But wouldn't it be easier to treat because you know the pathways?
You would think it would be easier to treat. I don't know if, yeah, I don't know. I got nothing for you. We can look for it. Again, I'll sound smarter next semester if we look into it. Questions before I keep going? So that just brings us into blood. We're just slipping straight into blood now. We'll go to alterations in oxygen transport. Now remember, you're getting oxygen because you breathe. You're getting rid of carbon dioxide because you exhale. That's all pretty important. How do you guys feel about the oxygen hemoglobin dissociation curve? What's that? You still what? You still hate it? Those of you who didn't have me for AMP2, did you guys study oxygen hemoglobin dissociation curve? Do we want a review here? Long time ago, and what was that? Was that a yes or a no? Don't recognize it? Yeah, if you don't immediately recognize it, we need to review it. We've got a lot of transfer students, so let's go ahead and review this. So what you're looking at on this chart, and again, this should be on your prep questions. This should have been something you prepared for, but it's one of those things that's a little bit more advanced. It does come up again, by the way. You're going to see this again in MedSurg. So I introduced it in AP2. You'll see it here. You'll see it in MedSurg. It doesn't go away. What you're looking at on this chart is on the x-axis, you have oxygen concentration, partial pressure of oxygen, just in general. Like you breathe oxygen, here's the amount of oxygen that was what you inhaled. That's pure oxygen is on this axis. On the y-axis is the percentage of oxygen in your bloodstream that is adhered and bound to hemoglobin molecules. So oxygen saturation of hemoglobin. So when it's 100% saturation, that means every single hemoglobin molecule is going to have 4 oxygen molecules bound to it. So here's our normal. In general, what you expect is that as oxygen in the environment increases, the binding of oxygen to hemoglobin increases. And for a very long time, that is true and correct. It's just there's a certain point at which you kind of meet saturation. Your hemoglobin actually doesn't like to be bound to all 4 chemically. That's energetically kind of expensive thing to do. So even if we introduce more oxygen, we're not always binding 100% hemoglobin. And that's just normal for that curve to taper off towards the top there. That's why you're looking at the curve looking like that. What's up?
But was it different like at different altitudes?
We're about to talk about what this blue line and this purple line mean and the factors that change the binding of oxygen to hemoglobin. Yeah, That's the topic. It's not directly about altitude, though. But you're right in thinking that there's factors that affect them. Okay, so that's our normal. Our normal line is illustrated in red on this middle line here. And we're going to see that there are some factors that are listed here and here respectively that are going to change the ability of oxygen to bind to hemoglobin, or rather the ability of hemoglobin to bind to oxygen. This might be a better way to say that. When you introduce more oxygen, but not as much of it is bound to hemoglobin, we call that a right shift because of the way it appears on this graph. So you can see we're moving along the x-axis, we're introducing more oxygen, and yet it takes considerably more oxygen to get equal binding of hemoglobin. Does that make sense? Okay. And that we would call a right shift. A weaker connection between oxygen and hemoglobin is a right shift. A stronger connection between oxygen and hemoglobin is a left shift. Even with less oxygen in the environment, more of it is bound to hemoglobin, or with less oxygen, an equivalent is bound to hemoglobin, as you can see there, if that made sense. So here are the factors that shift this line. Temperature is a really big one. An elevated temperature, maybe you have a fever, maybe you're in the Sahara Desert. An elevated temperature causes a right shift. It means there's a looser connection between oxygen and hemoglobin. Colder temperatures, maybe you're hypothermic, that's going to cause a tighter connection between oxygen and hemoglobin. And hemoglobin will not release oxygen as easily. So far, so good? Okay. The next factor is pH, acid-base balance. In acidic conditions, which is a low pH, we're talking less than 7, in a low pH acidic environment, that will cause a right shift. That will cause dissociation between oxygen and hemoglobin. And an alkaline environment that is a high pH, pH of over 7, that will cause a left shift. And our final factor that we're going to talk about is carbon dioxide concentration. Now, if you ever took like a Gen Bio or a chemistry class, one thing you may have learned that is if you bubble carbon dioxide through water, does anybody know what you get? Carbon dioxide bubbled through water, CO2 plus H2O. If you took AMP2 with me, you should know this. Yeah, we did a lot with this. Not bicarbonate. It's in a pathway with bicarbonate, so you're not far off. Your brain's going to the right place. Nope, you're thinking of cellular respiration, but thanks for speaking up. I appreciate it. It is right there. It's carbonic acid. Yeah, so what we mean here is that elevated carbon dioxide floating around your bloodstream is going to make you more acidic. So in my opinion, you can directly connect the idea of elevated carbon dioxide to an acidic environment, and then you can simplify your studies here and say that's going to cause a right shift. Yeah, respiratory acidosis, respiratory alkalosis. That is 1000% what we're going to lead into with that eventually. Yeah. Yeah. So carbon dioxide is going to correlate with acidity, and we already know that acidity is going to cause a right shift, which is a weaker connection between oxygen and hemoglobin. Good? Therefore, low carbon dioxide level is going to make you more alkaline, and it's going to cause a left shift. So you can really lump carbon dioxide and acid-base balance together and just make it into one factor. That's what I do in my head. Again, it's very significant clinically. Carbon dioxide, when we get to breathing, we're actually almost gonna care about carbon dioxide more than we care about oxygen. Yeah, oxygen is really important for cellular respiration, like you brought up. We need ATP for our cells to keep them from that hydropic swelling we talked about last week. But that acidosis, that alkalosis, That's going to be an immediate issue when people stop breathing. Okay, do you feel good about this? Or at least if you listen to this lecture 500 times, you'll feel good about this.
You had to write that graph.
That graph is rough. Let me know if you want to spend some more office hours time on it. Since we did do this extensively in AMP2, I'm going to move on though. And again, carbon dioxide is transported a number of ways. We'll have it as sorry, I can't pronounce that. We'll have it bound to hemoglobin. Only a small percent will be dissolved in CO2. So you really need to have a very elevated CO2 level before that dissolved CO2 becomes carbonic acid, but it will. Okay, more ideas associated with blood. Now again, role of blood. Red blood cells are there to carry oxygen, transport. The blood in general is transporting carbon dioxide. So our first sort of disease state associated with the blood is going to be anemia. And in general, anemia is deficit of red blood cells. When you have a deficit of red blood cells, you have low oxygen carrying capacity, and then you're in danger of developing hypoxia, which again, from last week, that's different from ischemia. Your nutrition is still being transported in this case. It is only oxygen that you are lacking. The opposite of anemia, of course, being polycythemia, as we just addressed in our sort of myeloid stem cell line. Now, too much or too little are both bad. Too little, low oxygen carrying capacity. Too many, that's going to increase blood viscosity. What's our danger of having elevated blood viscosity? Clotting. We're worried about clotting.
And then with anemia, isn't it also death?
Bruising easily, it can go with anemia. Bruising, yeah, I mean, it's going to be related to your clotting ability. So I would be more worried about clotting factors, fibrinogen, platelets, things like that. Okay, here's a lab test known as a hematocrit. We centrifuge a blood sample. Heavier things sink to the bottom in that centrifuge. What's our normal hematocrit? What's the percentage of formed elements? Nope. I have a specific number in mind. I imagine in lab results there's a range that you would consider normal. I heard it. 45. There we go. It was quiet though. That's good. So 45% formed elements approximately. 44 should be red blood cells. About 1% should be buffy coat, which includes white blood cells and platelets. The rest should be plasma. There's important stuff in every single layer here. But when we're defining anemia, there's actually a couple of ways you can have anemia. After this, we'll go on break, but we'll finish anemia first. Relative anemia. So here's, let's say I did a proper 45%. I had to make this out of just shapes because I couldn't find an image online, which makes me feel like people would be mad at me for the way that I made this image. We're just going to roll with it though. So let's pretend this is the normal 45% hematocrit. Let's pretend I actually made those proportional. There's absolute anemia, which means that you absolutely have fewer red blood cells, either because you decreased production of red blood cells or you are increasingly destroying your red blood cells at an accelerated rate. Something's wrong with the red blood cells and your spleen is having a field day. That would be absolute anemia. Relative anemia would be harder to detect. Relative anemia, the test results may actually no, that's the wrong way to say that. The red blood cell mass is actually normal, but there's a disruption in the regulation of the plasma volume. So if you only took the same sample size as you took before, it would show up as anemic, but the reality of the blood volume is that there's more plasma relative to red blood cells, and the actual total red blood cell count is the same. That's relative anemia. Did I say that in a way that made sense? So I initially said that kind of incorrectly. So let's go through that again. So you have a normal blood sample and it's 45% formed elements. Then let's say you took another blood sample and it looked as though that person was anemic. But if you could count every single red blood cell in their body, it would actually be a normal number. and they would just have more plasma volume, so that proportionally, when you centrifuged it, it looked like anemia. That's relative anemia.
So if my anemia would be bad, like with
Having too much plasma, you're going to have 4 whole weeks this quarter about fluid volume and where fluid volume's going. Fluid in the wrong place is bad. That's all I'm going to say for now. You've got 4 weeks of it coming up. We'll get into some of the causes in a second. We're going to be more focused on absolute anemia, though. So absolute anemia means we decrease production or we increase destruction, and that means there is less than 45%. There's less than 44% red blood cells because of one of these factors. There are so many things that can cause anemia, but it is time to go on break. It's 9:51. Be back in your seats at 10.